So we started now?
Just a second.
Okay, so hello
Hello.
everyone.
Okay, go ahead, Dr. Afrah will lead the meeting. Thank you everyone for joining the meeting. You can go ahead.
Okay, so hello everyone. Today is March 12, 2022. We, Yellow Team, and me, Afrah Shrabi, as a Yellow Team leader, will hostage the presentation today. We will start with Sarah Ahmed. She will present the stroke and cerebrovascular disease. So go ahead, Sarah, please.
Yeah, okay, I'll do that. Just a minute. I'm just sharing my screen. Okay, so do you see it, everyone?
Yes.
Okay. Okay. Hey, hello everyone. I am happy today to present about stroke and cerebrovascular disease, an area that really interests me. Time is brain is a famous quotation in treatment of stroke. Do you hear me, everyone?
Yes.
So it's a famous quotation about stroke that actually time is brain. I was honored to be interviewed by the person who said this quotation, the first one, and it's being used in the treatment of stroke, that like the faster you give the treatment, the better the outcome. So here are the epidemiology of stroke. We see in this graph that the most common type of stroke is the ischemic stroke is more common than the hemorrhagic stroke. There is a type called unclassified stroke. And as well, we see that among elderly, like from 75 to 85, we see that the frequency and the incidence of stroke is more than other population, which is give us a lot of interest as geriatrics, as we are interested in geriatrics to know about stroke. Stroke is the 5th leading cause of death in the US. The incidence is around 8,000 people every year. It's a leading cause of disability, and the incidence of stroke, despite that the incidence has declined, but the morbidity has increased because patients are living longer. The lifetime risk of stroke is higher in females. And globally, at least 5 million people die from stroke and millions of others remain disabled. Like there is a lot of development in the treatment of stroke that was happening in the last 10 years, which has helped a lot in the patient living longer, but we are still, people are like patients with the stroke still suffering from like its comorbidity, like its disability that causing it. That's why it's a very important topic, and a lot of research are going on regarding the treatment of a stroke. So regarding the classification of the stroke, there is 2 types. The first one is hemorrhagic, both like intracranial hemorrhage or subarachnoid hemorrhage. In those hemorrhage, the symptoms and signs are mainly due to pressure of the like surrounding brain tissue. Like the other type and the more common type is ischemic stroke. For ischemic stroke, there is 3 causes, like 3 things that can cause ischemia, either thrombosis, embolism, or systemic hypoperfusion. Thrombosis, the obstruction will be in the arterial wall itself, such as arteriosclerosis and dissection or fibromuscular dysplasia, and can be divided either like including large vessel like MCA or including small vessel like lacunar impact. In patients with thrombosis, the neurologic symptoms often fluctuate, remit, or progress in a stuttering fashion. The other type is embolism. For this embolism, the onset of symptoms is abrupt and it's usually maximal at the start. So from the clinical picture and presentation, you usually you would be able to kind of differentiate between what is causing this. For the embolic, it's most likely cardiac in origin, and atrial fibrillation is the most common cause. See, for systemic hypoperfusion, like patients with hypotension due to septic shock or other reasons, or cardiogenic shocks, or even after cardiac arrest, they can present with symptoms and signs of a stroke, and the symptoms of the brain dysfunction are diffuse and non-focal. Like you would not find that they have like massive left side weakness or right side weakness. It would be like more like non-focal symptoms like delirium or other things. We're gonna, like, if you're talking about the stroke, definitely we need to talk about transient ischemic attacks. So there is two definitions actually. There is one based on tissue and the other one is based on time. So the tissue-based definition of TIAs is a transient episode of neurologic dysfunction caused by focal brain, spinal cord, or retinal ischemia, but the most important thing is without acute infarction. If there is an acute infarction, this is a mini stroke, but if there is no acute infarction, this could go to the TIA. But there is actually time-based definition as well, as the TIA defined as neurologic dysfunction or neurologic symptoms that last less than 24 hours. So it needs to be less than 24 hours and it needs to be without acute infarction. In a population-based cohort study from 1948 to 2017, actually over 14,000 predominantly white participants from Framingham heart study, the estimated overall incidence of TIA was 1.19 per 1,000 person year. The incidence increased with age. For the age group 45 to 54 years, the incidence is 0.22 per 1,000 person year, while for the age group of 85 to 94 years, the incidence was 4.8. We see the difference between 0.2 to 4.8 for the patient for the age 85 to 94. Here is I got this from UpToDate. About the treatment and management. We see a lot of patients, like for those who are going for internal medicine or like neurology or even in geriatrics, there's a lot of, or even in primary care, you see a lot of patients present with symptoms that actually are TIAs. So it's mainly, I don't know here, but I think it's neurology see them, but at least you have to know the ABCs. And the management, the long-term management of a stroke. So for patients with the TIA or minor ischemic stroke, that like not eligible for thrombolytic therapy. There is some criteria that for patients will be eligible for thrombolytic therapy. TIA definitely and mini strokes are not. So in this, the treatment will be antiplatelet therapy, either dual antiplatelet therapy or only aspirin monotherapy. And there is a lot of things that would make you choose either dual antiplatelet or aspirin. There is an ABCD2 score that to make you know the risk of developing other TIAs. That A stands for age, B for blood pressure, C for clinical scenario, D for diabetes and disability. So this score actually give you an idea whether you would give them dual antiplatelet or aspirin. If there is like need for long-term anticoagulation, like there's atrial fibrillation or so, you start this. For evaluation, you actually need an emergency brain imaging, either CT brain or MRI. You need vascular imaging of the external cranial and intracranial arteries, like MRA or CTA. You need as well cardiac evaluation, including ECG, cardiac monitoring, echocardiography to kind of find out if the source is cardiac, and then laboratory tests. And then there is as well an area for secondary prevention. For secondary prevention, if there is like atrial fibrillation, you give anticoagulation. If there is artery stenosis, you do carotid artery surgery. If there is small vessel disease, there is like an area for like using dual antiplatelet therapy for a specific reason, and accordingly, there's details here. But the secondary prevention include treating the cause, excluding if there is carotid artery stenosis, or are giving antiplatelet therapy. There is other secondary prevention. I will talk about them in talking about secondary prevention in a stroke in general. So the problem in treating patients with TIAs usually resolve in 24 hours. Why are we worried? That's the important question here. So the important question is it's important to treat and investigate and do the workup in 2 days, to make sure, because they are at risk of developing other stroke. So the first days after the event are very important. The risk of developing a stroke after TIA is found to be 8% in the first 48 hours. If there is vascular pathology, if there is atherosclerosis, if there is carotid stenosis, if there is any significant vascular pathology, there is a lot of risk of developing a stroke. TIA is a warning that there is something is happening that you need to treat before the patient develop massive stroke and get worse and be disabled. And then there is higher risk of developing a stroke with infarction. Some TIAs, like CT brain, cannot see like small infarction, less than like 1 milliliter. So if you do an MRI or if you do the DWI, the diffusion weighted imaging, you find you can see very small infarction. So a lot of cases who are diagnosed as TIA actually are mini strokes, and those who have these mini strokes are actually at risk of developing other bigger stroke. That's why we need to start our anticoagulation, treat carotid stenosis or whatever the reason, try to go and treat it as soon as possible. So is the stroke risk after TIA declining over time? Actually, there is a systematic review and meta-analysis of 68 studies published from 1971 to March 2019 that included over 2,000 patients, found that the risk of a stroke after TIA was 2.4% within 2 days, and 3.8% within 7 days, and 4.1% within 30 days, and 4.7% within 90 days. Okay, the number is increasing, but actually it's considered like decreasing, because if when you compare 2.4 to 4.7 in 2 days compared to 90 days, so that's considered like the amount of increase considered slow. So the time, like the first week, is the most important time to kind of find out the reason of the TIA and treat it. So let us talk about risk factors of TIA and cerebrovascular accidents in general. The first one, and is the most important and common, is hypertension. Epidemiological studies actually show that there is a gradually increasing incidence of both coronary artery disease and stroke as the blood pressure rises above 110/75. Other risk factor is dyslipidemia. Smoking definitely increases the likelihood of extracranial occlusive vascular disease, nearly doubling the risk of stroke. The risk of ischemic stroke decrease over time after smoking cessation. This is an important factor you mentioned to the smokers that would give them like they will be like, okay, we will stop it because it will decrease the risk. Other last thing is physical inactivity. Here there is a study, like Korean study, showing that blood pressure, like in this cohort study, so that every increase of 20 millimeter mercury increase in systolic pressure, that will increase the relative risk of hemorrhagic stroke. And this is even more than ischemic stroke. So increasing blood pressure, increasing the risk mainly of hemorrhagic stroke as well as ischemic stroke. And the relative risk was 3.1 for hemorrhage and 2.2 for ischemic. Unmodifiable risk factors are older age, as we said earlier, age more than 80 years are at higher risk of stroke, race and ethnicity, with the risk higher among Black more than white. Sex, the risk is higher at most ages for men compared with women, except for ages 35 to 44 years and age more than 85 years. Where women have a similar or higher risk than men. So the men have a higher risk compared with women, but during like lifelong, because the woman, like when the risk more than 85 and most of the patients getting strokes are actually above 80, that makes women actually getting strokes more than men. Family history and genetic disorders are other unmodifiable risk factors, with higher risk for monozygotic twins and those with genetic disorders such as sickle cell disease or cerebral autosomal dominant arteriopathy with subcortical infarction and leukoencephalopathy. So there is other risk factors. The most important one is heart diseases, including atrial fibrillation, valvular disease, recent MI, and endocarditis increase the probability of a stroke due to embolism. As I said earlier, there is thrombosis and there is embolic factors. And when it's embolic, it's most likely due to heart disease, and the atrial fibrillation is the most prominent, causing nearly half of all cardioembolic strokes. So having monitors, cardiac monitor, is the most important test to do for those patients who present either with a stroke or TIA, to find out about the rhythm of atrial fibrillation, so you can anticoagulate and prevent them from having other strokes. The risk of stroke appeared to be greatly increased after myocardial infarction, particularly in the first 30 days. So patients with MI have increasing risk of stroke. Diabetes is another risk factor, and the likelihood of large and small artery occlusive disease and ischemic stroke, but it has not shown to predispose to hemorrhagic stroke. So diabetes increases the risk of ischemic stroke, not hemorrhagic stroke. While amphetamine, patients who take amphetamine increase the likelihood of both intracranial hemorrhage and subarachnoid hemorrhage, but not ischemic stroke. Cocaine, on the other hand, causes both hemorrhagic and ischemic. Then a patient presented with left-sided weakness, and you're the first one to encounter this patient. You first assess the patient, ABCs all the time, make sure that the airway is patent, breathing, oxygen saturation, circulation, like blood pressure, give IV fluids and all that. Then we do quick history and examination to help to distinguish stroke mimics and other disorders in the differential diagnosis. We know that migraine can mimic stroke, sometimes seizure, and all that need to be excluded. The third thing is you do the imaging, like urgent brain CT, MRI, and as well now it needed to do CT angiography or MRI angiography to look into extracranial and intracranial arteries to some patients need intervention with that. Then you manage volume depletion and electrolyte disturbance. Most important blood test is serum glucose. Make sure that patient is not hypoglycemic. If there is hyperglycemia, treat it. And then assessment of the swallowing is an important factor, because it used, I know back home, like in Sudan, a lot of stroke patients actually die from aspiration. So having full swallowing assessment and put them MBO is very important, at least for the first 24 hours and until full assessment done. Then other things need to be done is optimization of a bed position. Usually you put it 30 degrees. If patients are okay, they're not at high risk of complication, you can keep them wherever they're comfortable. Fever is an important to treat, because there is associated increase in mortality rates, greater disability, more dependence, and worse functional outcome if fever is not treated well with patients. We know that fever can make the brain function worse, so it needs to be treated. Here is a study and meta-analysis found that fever within 24 hours of hospital admission in patients with ischemic stroke was associated with actually twofold increase in the odds of mortality at 1 month after stroke onset. So here, this a scoring system that is international, that the National Institute of Health Stroke Care, called NIHSS. This score actually, you do a quick neurological exam. There is a score for each feature, like level of consciousness, following command, eyes, gaze, visual, facial palsy, motor function in the left or right arm, the leg, ataxia, sensory, language, dysarthria. You're actually assessing all the neurological function, and you get a score from 0 to 42. And if the stroke is less than 5, they're most likely minimal stroke. So it doesn't need further Transpolitic or thrombectomy treatment, only the treatment of a stroke, the aspirin and other stroke care. While if it's more than 5, definitely need intervention and treatment, as we will talk in a minute. Acute therapy for stroke include thrombolytic therapy and thrombectomy. Thrombolytic therapy, mainly I'm talking now about ischemic stroke. Hemorrhagic stroke is a different scenario. They have completely different treatment. Thrombolytic therapy of ischemic stroke is alteplase. It's the most famous drug. It's a first-line therapy, provided that the treatment actually initiated within 4.5 hours from the start of the symptoms. Let us keep in mind that there is wake up from sleep, stroke, and other things. They have specific situation that we need to make sure, but in general, it's 3 hours actually. And then between 3 hours and 4.5 hours, those patients who present in this timeline, there is a specific consideration. For example, elderly above 85 need to make sure that we usually thrombolize them before 3 hours. So between 3 and 4.5, you need to it needs some consideration. Because of the benefit of the alteplase is time dependent, it is critical to treat patient as quickly as possible. So treating a stroke mainly depend on time. Mainly the thrombolytic therapy, what they do is actually it's a medication where it helps it to dissolve the thrombus. So it will restore the blood supply to the area with infarction, help to restore that blood supply. Like there is exclusion criteria, as most of us probably heard, that giving the thrombolytic therapy, if patient have like head trauma, intracranial hemorrhage, or gastrointestinal malignancy, hemorrhage, or if there is history suggestive of hemorrhage, high blood pressure, this is the most important one. We have to make sure that the blood pressure is less, the systolic blood pressure is less than 185, and the diastolic is less than 110. Other like hematological and HCT finding, like if there is any evidence of hemorrhage as well, that would be exclusion criteria for giving thrombolysis. So care should be taken for giving this medication because it's a strong medication and it has side effects. So timeline is important. So most of the stroke centers actually, they look to achieve that door to median time is less than 60 minutes. Like patient arrive, assessed, and like getting the evaluation, getting the calling the stroke consultant, do the CT, interpret the imaging, and give the alteplase actually in less than 60 minutes, and that will provide the best result for patient outcomes. Other acute therapy is mechanical thrombectomy. It's indicated for patients with acute ischemic stroke due to a large artery occlusion in the anterior circulation. So it needs to be large artery in the anterior circulation who meet the eligibility criteria and can be treated within 24 hours. So doing the thrombectomy is have like longer window up to 24 hours. From the last known to be well, like the patient at neurological baseline, regardless of whether they receive intravenous alteplase for the same ischemic stroke event. So some patients receive both. For age 80 years and older, they appear to benefit from thrombolysis despite a higher mortality rate compared with younger patient. So we do not consider age to be contraindication to thrombolysis. However, if the age more than 80, it's a relative contraindication in the 3 to 4.5 hour, as I said earlier. In 2014, a meta-analysis of individual patient data from around 6,700 subjects, including more than 1,700 subjects older than 80 years, they found that benefit of alteplase was similar regardless of the patient age. So that's confirmed what I've said earlier. And in a pre-specified secondary analysis of individual participant data from a 2016 meta-analysis of 9 trials, alteplase versus control for acute ischemic stroke, the increased risk of intracerebral hemorrhage with alteplase. So those patients with 80 years and older, they benefit from the alteplase. However, they have greater risk of developing hemorrhage, which is a known complication or side effect of alteplase, that it can cause hemorrhage actually for patients. I have seen it in few patients actually, but it's still the benefit is higher than the risk of hemorrhage. Older age is not an exclusion as well for mechanical thrombectomy. So older population, they receive their treatment, either thrombolysis or thrombectomy. Other treatments for acute ischemic stroke are like antithrombotic therapy with aspirin, should be initiated in the first 48 hours onset. You give prophylaxis for deep venous thrombosis and pulmonary embolism. You make sure that you're giving the antithrombotic therapy at discharge. Give a statin for lipid lowering medication. Make sure that you reduce the blood pressure, and you advise the patient for behavioral and lifestyle changes, including smoking cessation, exercise, weight reduction, and Mediterranean style diet. Let us talk about something that we face as well a lot, about pain control in patients with acute blood pressure control in acute ischemic stroke. Actually, emergency hypertension can cause stroke. So patients present with ischemic stroke, but we have to kind of balance the kind of treating the blood pressure, but we still need the high blood pressure to make sure the supply of the area with infarction. So treating this blood pressure need to be cautious. And the other factor is we do not like thrombolytic therapy. We cannot give it if the systolic blood pressure is more than 185 or the diastolic more than 110. So we need first to make sure that to decrease the blood pressure below this level to give the thrombolytic therapy, but then we need to take caution to decrease it more and more over the next 24 and 48 hours. So it needs to be under monitoring, definitely in the ICU. Here, like the medication used are labetalol, nicardipine, clevidipine. This is what used before the thrombolysis, but during and after the thrombolysis, again, it's labetalol and nicardipine and clevidipine, but it's smaller doses because caution should be taken during this. If this doesn't help, nitroprusside is the second line therapy, but like just it should be just taken care because there is risk of increasing intracranial pressure and affecting the platelet, which it will increase the risk of hemorrhage after stroke. Then carotid endarterectomy for carotid stenosis. In general, the benefit of carotid revascularization for stroke risk reduction outweigh the risk, particularly when performed within 2 weeks of the presenting event. So basically we do like neck ultrasound or CT angio to kind of, if some patients present with mini stroke or like medium stroke and they have carotid stenosis, this will get them risk for another larger stroke. Depending on the condition of the patient, they will be eligible. If there is like above than 50% stenosis, they will be eligible for carotid revascularization. But when patients have massive stroke already, and they have like large MCA stroke, and they are already disabled, they usually just don't do the surgery because there will be no any benefit. Here, the hemorrhage, assessment of hemorrhage in the emergency department. Again, ABCs like airway, and then neurosurgical consultation, and make sure that patients who need surgery, patients with cerebellar intracerebral hemorrhage with either more than 3 centimeter diameter or causing brainstem compression, those need surgery. If there is interventricular hemorrhage or with obstructive hydrocephalus and there is a patient is deteriorating, if there is hemispheric intracerebral hemorrhage with life-threatening brain compression, like they are at risk of herniation, this is an indication for surgery. Other thing is if they were having this hemorrhage because they were taking anticoagulation, you need to give you need to reverse the anticoagulation. If they're taking warfarin, you give the 4-factor BCC or vitamin K, dabigatran. They have their specific antidote, factor 10 inhibitor, and heparin. Make sure to kind of reverse the cause of the hemorrhage. This is the emergency treatment if there is hypertension causing intracerebral hemorrhage. We were talking about hypertension causing ischemic stroke earlier. Now hypertension causing intracerebral hemorrhage. There is different approach because here the immediate treatment reduces the blood pressure below 220. So you give nicardipine, and you check the blood pressure, typically do it like stepwise treatment, because you can worsen the neurologic function if you drop the blood pressure fast. Other thing is manage the elevated intracranial pressure, and repeat imaging, and you can even give hypertonic saline and mannitol if there is increased intracranial pressure. Here, stroke patients are very vulnerable patients, are sick patients. So they need to be treated in a very specific area, like a stroke unit. Patients with acute stroke have better outcomes when admitted to a hospital unit that is specialized for the care of patients with all types of acute stroke, including ischemic, intracerebral hemorrhage, and subarachnoid hemorrhage. It's what is a stroke unit? It's a hospital ward with dedicated telemetry beds that is continuously staffed by a stroke specialized team of physicians, nurses, and other personnel, emphasizing expertise in vascular neurology and neurosurgery. There is also should be prompt availability of neuroimaging, CT, MRI, or other types, and cardiac imaging. So they need specific care, those patients, specifically in the first 48 hours. We are going to talk about secondary prevention of TIA or ischemic strokes. The management of treatable risk factors and common mechanism of brain ischemia is important for reducing the risk of ischemic strokes in future. The first thing of preventing secondary prevention of CVAs is aspirin, clopidogrel, and a combination of aspirin extended release dibridamol. There's a specific guidelines of when you use aspirin, when you use clopidogrel, when you use both. Okay, for long-term treatment. They will probably, if someone got a stroke and it's according to their risk, they need aspirin for life. Other thing is anticoagulation. For patients with ischemic neurologic symptom caused by cervical artery dissection, antithrombotic therapy is indicated, but the choice between antiplatelet or anticoagulation is kind of controversial. If patients have chronic non-valvular atrial fibrillation and develop ischemic stroke or TIA, they need lifelong anticoagulation with warfarin or factor Xa inhibitor. We know that according to the CHA2DS2-VASc score, anything above 2 need to long-term anticoagulation. Second thing is management of the hypertension, long-term management of hypertension. The 2021 American Heart Association and Stroke Association guidelines recommend an office measurement blood pressure goal of less than 130/80 for most patients to reduce the risk of recurrent stroke and vascular event. So the blood pressure need to be less than 130/80, and then lifestyle modification that's shown to decrease blood pressure should be included as well with the medication, including weight loss, salt restriction, diet rich in fruits, vegetables, and low-fat dairy products, regular aerobic and physical exercises, and limiting alcohol consumption. So all that included, they can actually decrease the blood pressure and subsequently decrease the risk of developing a stroke. Statin is the best studied and have proven efficacy for reducing the risk of recurrent ischemic stroke. If there is any intolerance or contraindication, we can use ezetimibe to keep the LDL more than 70 milligram per deciliter. Diabetes, for most patients of diabetes, the goal is to keep hemoglobin A1C less than 7. Diet, exercise, oral hypoglycemic drugs, insulin, they achieve glycemic control. However, tight glucose control reduce actually the microvascular complications of diabetes, not the macrovascular outcomes like a stroke and death. So anyway, we give we advise like tight glycemic control for any diabetic patient to prevent the microvascular complication. Again, lifestyle modification. In the nurses' health study, smokers had a relative risk of stroke of 2.5 compared with never smokers. The evaluation of former smokers found that the excess risk actually disappeared within 2 to 4 years after cessation of smoking. So, as I said earlier, this would be the advice. Like, if you tell this to the smoker, you might make them more kind of enthusiastic to quit smoking. In the Framingham heart study, the odds ratio for moderate carotid stenosis was 1.08 for each 5 pack of years smoking. So it can cause like an increased risk of stroke through causing atherosclerosis, like moderate carotid stenosis. Patients with ischemic stroke or TIA who are capable of regular exercise should engage in moderate intensity physical exercise performed for a minimum of 10 minutes 4 times a week, or vigorous intensity exercise performed for a minimum of 20 minutes twice a week. Like, exercise is important in preventing vascular events. For patients with history of stroke and TIA, it's advised to follow a Mediterranean type diet with emphasis of intake of vegetable, fruits, all this healthy kind of food, and low-fat diets, eat more fish and all that. And those patients who have like blood pressure issue, they advise as well to take low sodium intake for at least like 1 gram a day. And that's the presentation, and hope you enjoyed it. If anyone have any question, please, you can just go ahead.
Thank you, Dr. Sarah. Thank you so much. So does anyone have any question?
Excellent presentation, Dr. Sarah. Thank you so much. It's a big topic, and you put it in a nutshell. It's just concise, to the point. I think you covered most of the important part. I think there is a question in the chat.
Yeah, she mentioned that if we talk about rehab next time, yeah, this is a very good point. Actually, in the rehab area, I would say like the multidisciplinary team is most important in treating stroke patients when they move from acute care to the rehab. Actually, the speech and language therapy, the occupational therapy, physiotherapy, clinician like physician, geriatrician, or like rehab physician, like looking after the social worker, like deciding whether they are able to go home, need long-term care. This is actually what usually done in rehabilitation, and it's actually a great area. You see actually how patients benefit from this multidisciplinary team. I used to work in stroke rehabilitation before, and those meetings, like when you see all the multidisciplinary team, each one talk about the side of a patient actually and come to a final decision, and sometimes including the family actually, and seeing the progress of the patient weekly, for example. This actually like has a great benefit for those patients, and it's really an important area actually for these patients. Thank you.
Thank you so much again.
So no questions.
So just my last slide for tomorrow. The successful people make the most of the best, and the best of the worst. So good luck everyone tomorrow, and like you did great, and hopefully everyone will match tomorrow. But if not, just it's our journey, and it doesn't mean anything. That it's just you need like. You do it again and you will get it finally. Hopefully everyone will get it, and thank you. Thank you very much.
Inshallah, everyone will get the congratulation email on Monday. Thank you, Dr. Sarah. So if there is no question, we can go for next topic. which is the grant writing with Dr. Somi.
I think this presentation will be presented by me and Dr. Lubaba. So Lubaba, I have a question. Do you want to start? And I will or should I start? Either way is okay with me.
Yeah, sure. Good afternoon, everyone. I'm sorry for joining late. Yes, I will talk briefly about it, and then you can take it over and add your project as well.
Sure.
Okay, allow me to share. Okay. I think I have something open. Not sure if you can see my screen or.
Is it
You see the Zoom or my screen?
the screenwriting a grant proposal? And,
Okay.
yeah.
The problem is my view is blocked with something here.
I think it's the view is good too.
Yeah, so okay, now I think it's better. So actually this presentation, we did it last year. My colleague, Dr. Ali and me, we presented briefly about writing a grant proposal. The grant proposal is usually a complex kind of process with a lot of back and forth between people involved in this process, but I will try to provide a general idea and basic understanding for it, and then we will talk from there. So objectives will be like, what is a grant proposal and what are the principles for grant proposals, and if there is any prerequisite to writing, and what are the common mistakes that we should avoid them. And we provide an example of NIH grants and the types of it, and how it's the NIH specifically grant proposal are written. So to define grant proposal is a very clear, direct document written to a particular organization or a funding agency with the purpose of persuading the reviewers to provide you with support because you have a great and important, fully considered plan, an idea that you want to advance a valuable cause, and you are responsible and capable of realizing that. So this is basically from University of Wisconsin. There is a lot of definitions for grant proposal, but all of them around these areas. So what are the grants? So the grant is a financial award given by a foundation or entity to a recipient to carry a project or a program to benefit a greater good. So these entities could be government, could be family trust, could be corporates or communities. And usually when you're searching for grants and grantors, you can look for grants.gov or Google or GuideStars or nonprofit Insight, and universities as well, and local corporation, and etc. for finding grants for your project. So the basic principles of grantmanship is, as we said, like a good idea. You have an idea that you want to share and you want to produce something new. You have to write a successful grant application. You need to know the system and how is that going to work. And the most important, I think, part of the principle is don't quit. As I mentioned earlier, it's a complex kind of process with a lot of back and forth, but you need to utilize the criticism and revise and resubmit again and again until you reach your goal. So some of the criteria for the grant application, for example, in NIH, the application has to have a great significance for your projects, what is going to add to what's currently available. Is it a new idea? It has to be an innovative idea as well. You as an investigator or your collaborators has to have expertise in the area of the project that you're gonna present. And you have to detail the approach, how you're going to fulfill this project or this program, and definitely the environment that you're going to work at. So before writing, we talked about the idea, so you have to develop your plan. The grant proposals are direct and to the point. So you need to be very, your message has to be very clear in delivering your plan and your idea. And you have to clarify and formulate your ideas clearly, as I mentioned. Develop a specific and meaningful, actionable plan for what you want to do and why you want to do it. So as we mentioned earlier, the approach has to be very detailed in the grant application, and that's really this area talked about. So and you consider your plan will achieve a positive results, and you need to share that how you're gonna provide kind of considerable. So one of the smart uses of developing your idea or your plan is to use the acronym SMART, which is stand for specific. So you need to make your goal is direct and detailed and meaningful, and you have to provide kind of quantifiable and measurable goal with that easily to be tracked, and you kind of be able to provide the success of your project. So it needs to be something that's measurable, because if you receive a funding from any entity, they will need a progress report every now and then. So it needs to be very clear and measurable. It needs to be attainable goal too. So it needs to have tools and measurements that can be attained in the real life. So, and it needs to be relevant to the, for example, when you apply for a grant, the grant will be specified for a specific area. So your proposal needs to be relevant to that specific area. And definitely it has to be a time-based, and it has a due date and deadline clearly provided. So in order to accomplish all of these, you need to build your team. So research is highly interdisciplinary and multidisciplinary, actually, a process, and it's not one person kind of job. Know yourself, your strength and your weaknesses, and know your collaborators that are going to support you, your seniors, your peers, and younger scientists as well, with a specific kind of assigning tasks and job, and according to each one expertise. So, so know the grant maker as well. So if you're reaching for an NIH, they will put some grants, as I mentioned, with a specific kind of requirement and prerequisite. So you need to study this very carefully and research the organization carefully, and write your application to fit what they need exactly, and make it match, so you will have a high rate of getting the grant funded from, or your project funded from them. So, and in the same area too, you wanna be really having a persuasive argument with them, whether they need like numbers, if you are doing any kind of project regarding let's say, an example of that, if something related to if the organization, for example, really very keen in knowing how you're gonna explain your budget and in numbers, in what are the salaries, what are the cost of the project. So if they are really big in numbers, you need to provide that. You need to go back to their previous kind of funded project from them, and know what are the area that they usually focus on, so you can focus on that in your application. Is it like their historical precedent on this area will help you a lot in providing what they need, and make your you have a high successful rate of getting this grant. You need also to read extensively and to be up to date on technologies, literature, emerging theories in the project that you're gonna present or propose. Definitely you need your program. We mentioned earlier that you need your idea to be innovative. So you need to be up to date on all of the area that's pertinent to your project. So there is about 25% of research grant application were incomplete and required that the applicant submit additional information urgently. So this is what makes the delays sometimes from the beginning. Even if your application is complete, but you missed kind of explaining your idea the best way, it might get rejected at the beginning, and you will be asked to resubmit, let alone when it is not complete. So to make a checklist and mark your calendar for your deadline that you provide, and you have to fulfill every element in your application before sending it, so you will have a better chance of getting a grant. Don't hesitate to ask for help. As we mentioned earlier, it's a kind of multidisciplinary process with collaborators, mentors, seniors, even junior scientists, all assigned with their expertise for the task. So don't really hesitate of reaching out and ask for help. Even, for example, the entities that provide grants themselves, they have like an officers, an area that you can reach out and give them like your grant application to review before you submit, and you take this critique and feedback so you can improve your application. In the process of doing that, you need to ask yourself who is the best entity that will provide me fund for this X project, and what I'm gonna present to them, what are my specific aims of this project. And definitely within the grant application, you need to show the method, and you need to show the budget. It's how the method and how much is the budget, and why you wanna do this project and where you wanna do it. As we said, the environment and the significance and all of those elements we talked about earlier. So the common mistakes that are like easy to be made is like unrealistic ambitious, too much work proposed that are not capable of doing it, and not clearly defined priorities and uncertain future directions. As we mentioned, it needs to be very clearly, and even with a deadline, when you're gonna finish, for example, stage 1, stage 2, something like that, if you are having something that's going to be done in terms. So, and your project is not innovative, that's lacking one of the important criteria, it's not gonna be granted those grant or funds. The common mistakes regarding the investigators, we talked about the investigators and the importance of providing like expert and make a team that with all of the elements that you need for your project. So if you miss to really talk about who is the principal investigator and what is expertise in the area that of your project, you might not get a grant, because that will be like it's unknown, or it's a jeopardy for using kind of money. It's usually the grants are financial and big things for big projects. Need to be really, everyone need to be identified clearly, and what is its role and what his expertise in that role before. The common mistakes in the approach. So you did not provide, we're going to talk about the approach and what are the elements of those the approaches. I mentioned the method of your project, for example, and the strategies that you're going to use. So if you miss one of those points, it will be really setback for the grant proposal. The budget need to be something realistic and justifiable. You need to justify every single bit that you wanna spend on the project, and it has to be realistic and something that would be applicable for your grant or for your project. So the types of NIH grants are really a lot. So, but one of the most common one is the research grants, which are R series, and it is numbered from R0 to, I believe, R30 or something like that, depending on what these grants are used for. Usually for training and career development, and usually include individual fellowships, institutional awards, career development awards, and other opportunities. There is a lot of small business grants as well within the umbrella of the NIH, National Institutes of Health. There is clinical research center grants, administrative supplements, as well as even loan repayment programs. If you have an idea for a program that will be funded, it will, I think that they can even pay for your loans for career or development of yourself. So the R series, as I mentioned, is the largest category of funding and support by the NIH. So R01, R15, and R21, all of these are available in the NIH website. So R01 is the largest single category of support provided by NIH, considered the traditional grant mechanism, usually provided for universities, medical and health professional schools, colleges and hospitals, research institute, and etc. Usually those grants are used for salary, equipment, supplies, travel, every single kind of spending on those projects. And usually it's given to the organization on behalf of individuals. For principal investigator under one of the institute, what will be given for the institute on behalf of the investigator. So briefly, how to write the NIH grant. Those are like kind of scattered information in general about grants and grant application. And so how to write the grant, we talked about the application itself. It considered to have a lot of elements and a lot of things that you need to add to your application. For example, introduction. The introduction would be your abstract of your project. And specific aims and research strategy. This will include the approach as well. So the specific aims states concisely the goals of the proposed research and summarize the expected outcomes and list the specific objectives of the research proposed. For example, test stated hypotheses, create a novel design, or solve a specific problem. And always remember, it has to be an innovative thing compared to what is currently standard. The strategy, so the significance of your project or program. So it needs to be explained, the importance of it and how the proposed project will improve the scientific knowledge or clinical practice, and how the concept, methods, technologies that derive the field will be changed if the proposed aims are achieved. It has to be innovative, again, explain how the application challenges and seeks to shift the current research or practice paradigms, describe any novel concept or methodologies to be developed, and any advantage over the existing ones. The approach need to be really detailed, describe the overall strategy, the methodology, analysis to be used to accomplish the specific aims. For example, data collection, interpretation, and resources sharing of the plans, discuss the potential problems and alternative strategies and benchmarks for success. Also for new and early stage projects, describe strategy to establish feasibility. And importantly, point out any situations or materials that may be hazardous to personnel and precautions to be exercised for this area. So for example, if you have a new application, it has to be a preliminary study. So you will include information for prelim studies as part of approach section, discuss the principal investigators or principal directors, prelim studies, data, experiences pertinent to the application for a specific type of award or grant. Preliminary studies are essential part. So this is really specifically for new application. But in terms of resubmitting, as we mentioned, it's a complex process and has a lot of back and forth. If you are resubmitting or even providing a progress of getting the grant for resubmission, you need to provide a progress report. It must be provided at the approach section again, and include beginning and ending dates for the period covered since the last comparative review. Summarize the specific aims of the previous project period and the importance of the findings, and emphasize the progress made towards their achievements. Include any significant change to specific aims or directions. Remember, we told that it might be returned or critiqued for some stuff. You need to change the specific aim. So you have to detail that change and state it clearly. List of publication manuscript accepted and other printed materials should be included as well. So finally, in general, the grant application would look like something that include those basic components. Summary or abstract, as we said, is part of the introduction. A statement of need or problem, which is the specific aim that we talked about. Your objectives, and you usually use the acronym SMART to make your objectives really valuable and really into the point. You need to state in your approach the method and the design. And evaluation, this is regarding the progress that you are attaining while you are doing your program. What are the points of evaluation that you're going to do for your program or project? The future funding, this would be something that if you granted if you receive the grant, if you receive, for example, part of the grant, what would be your resources for the future funding of the project? You need to state the budget, as we mentioned, clearly for every single bit. Money is a big thing. And management plan and key personnel, as we mentioned, you need to specify if there is any hazardous situation that might arise during your program or your project, and what are your precautionary measures to prevent that or to avoid that, as well as a conclusion and appendices of all of your resources and information about your PIs. So it's really complex, and I tried just to give like general idea about it. So writing a proposal is hard work, but the process ends, sometimes it ends with rejection, but take reviewer criticism seriously and not slavishly. That's briefly about grant writing and grant application. I hope that you find this beneficial, and I will leave you with Somi to talk about her project and how she managed to receive a fund. Thank you.
Thank you. Thank you, Dr. Lubaba.
You're welcome.
Thank you, Dr. Lubaba and everyone. Lubaba almost says everything, but still I'm sharing my project. Just give me 1 second to fix the form. Everyone can see my screen?
Yes.
Yes.
Yes, we can. So
All right. I think some of you already know about my project, but some of you may not know about my project, but just briefly, I am discussing about my project a little bit. So I am a master's student. I'm doing master's in global health at Michigan State University College of Osteopathic Medicine. I'll be graduating soon, but how this idea came to my how did I write that grant proposal, and I was able to manage the fund from this proposal. That's what I am going to talk about today. So through my master's program, there was a, like I can use basically 3 credit hours to do my independent research project. So when I talked to my mentor and then like what kind of project I can do and what not, so she kind of, she described me that I can write a proposal based on the community needs. And, then from that proposal, if my, if my grant was, proposal is accepted, I may get some grant from that. And that grant probably I can use for my tuition reimbursement towards my master's program. So I thought like that's a very good idea. And probably, as my goal is to basically in future, like, followed by residency, that to probably to go for academic career. So she also suggested me that it will be very beneficial for my academic career, because if I have a grant, before starting residency and whatnot. So that's how the proposal came. And my proposal was about, because that time was basically pandemic, it was last year, back around this time. So I wrote a proposal regarding like how to overcome vaccine hesitancy among underserved population. And so it's basically a health literacy program. So my program is basically, my major is public health and the minor is global health. So it is kind of a public health project. So, it's like a health literacy and how to educate people regarding vaccine hesitancy, safety, and efficacy. Because as we all know, that was a great bias, and people have some anti-bias attitude and whatnot. So, I thought it's anyway, this will be beneficial for the community, and, it will increase the vaccine rate overall, and also it will prevent the future pandemic. So anyways, this is the most common sections for the grant proposal. Like always you have to write a cover letter, and your cover letter should mention like, why you are interested for this project, and why this idea is important to the community, and why you are going to work that. As Lubaba mentioned, that executive summary, of course you have to summarize, and the summary should be very concise. And, I would say like a very point to point, because nobody wants to know like too descriptive summary or anything like that. You need to write, of course, a need a statement. That is same thing as Lubaba discussed, goals and objectives. Like what we are going to gain, or like what is my goals and what is our objectives for this grant or grant proposal or for this project. Methods, strategies, and program design, it has to be very, very unique, innovative, and well designed. So these sections are very, very important. If any of these sections are not clear, no matter how how strongly your proposal is, it's not going to be accepted. Of course, the evaluation section, like how your proposal is important, how you are going to evaluate your results or your goals or your objectives. Other fundings or sustainability. This is any kind of public health work. After working almost a year, I feel like this is a very, very important concept or important thing, that when you ask for a fund, probably you have to make sure that your project is sustainable. What that means, like, see, like I'm working this vaccine hesitancy program now. What happened? My program was basically for 12 months. So it's like a 1-year program. So if I leave from today, like, from my project, will that project sustain? Means like, is somebody will be able to take it over, or like, is there an opportunity that, any like other, I'm a fellow, but, if other fellow can join, or is there a possibility that we can extend the grant from the like the stakeholders or someone else. So sustainability is the big question for the public health workers. Information about your organization, and that is very relevant, and project budget. So you have to have that. I know that this was very difficult for me as well, like to evaluate the budget at the beginning, because I did not really do this kind of things in previously. So like I was not able to basically, I would say, anticipate that how much cost would it get related. Like let's say as I did some vaccine hesitancy campaign, and I did some health literacy flyers, some materials I had to print out, some of the campaign I had to organize. So like all those together, I did not have much idea, like how much really my project like budget. But eventually I have learned a lot, and I probably it will be better in next. So as Lubaba mentioned, that it was not that clear for me in the beginning. I just anticipate something and I put an amount and whatever, but eventually I learn, and I probably it will be better for my next project or next grant proposal. So always you learn from something, and then it will be better and better when you write a couple of proposals. So for here, so about my project, a little bit of background. I work in underserved population in Detroit area. I live in Michigan, and I work, my project focus was, as I mentioned, it is underserved population. And why this idea came to my mind, because when I was researching the data, I found that due to pandemic, there are because of multiple barriers, the overall vaccination rates for the kids as well as adults, it's declined. So the idea was, if we do not address right now, we probably inviting another pandemic in next couple of years, such as measles, because the kids are basically behind from the vaccines. So as like we have to develop herd immunity in order to prevent the pandemic. So if the kids missed the vaccine, so we'll not be able to achieve that herd immunity. So we'll be inviting another pandemic. So that's overall my project was. But at the same time, I want to focus COVID vaccines as well, because as this is a new disease, new vaccines, so the society already have a gap, the health information gap or communication gap, I would say, from the physicians to patient, that they most of the time physician, when a patient comes, we most of the time our priority is different. We talk about their disease, their symptoms, there are other diseases. Sometimes we do not have, as a physician, we do not have much time to talk about vaccines, efficacy, safety, side effect. But we should not, at the same time, we should not assume that they know everything. Especially for the COVID vaccines, I kind of understand that this was a big question for everyone, that how the vaccines, how do you know the vaccines are safe? What kind of side effect in the long run, in the short run? How did it work in my body? Something like that. So so I try to focus mostly on COVID, but also I include some other preventative vaccines, health literacy as well. So like Lubaba mentioned, any kind of before writing any kind of proposal, first you have to understand what is your research question. So your research question is most critical part of your project or your proposal, and it guides you your arguments and inquiry and provokes the interest of the reviewer. So always remember that your research question is very important. For my project, I always question myself why I am doing it. And did this community need this kind of education or this kind of knowledge, or will that helpful for the community? And is after I know that I cannot do it forever and ever. So if I even left, will that be possible that my project will sustainable? So those are the questions came to my mind before starting, and for my project. And then if your questions does not work well, no matter how strong your proposal, the proposal is unlikely to be successful. So that's why I want to emphasize that this is the most critical part of your proposal, that you have to have asked yourself that question before writing the proposal, that how strong I mean, what are the questions, and is that the questions you are able to answer yourself, and how is going to impact the society. Other than how strong your proposal, it is very unlikely that it would be successful. And so that's all of these reasons, it is very common to spend more time on the research, conceptualizing and forming of each individual word of these research questions than any part of the proposal. So this is very, very important. And when you have done all of those things, then you have, you should consider your research questions that should be equivocative, relevant, clear, and it has to be very, very to the point. Like, as I said, like, what is my goal? My research is going to be, is going to be impactful for the community or for the society I'm going to work, or I'm going to target those type of people. So those are the questions for any, before writing any proposal, you have to answer. I mean, I think you have to go answer those things. You have to research the data, like, is that, like, is it helpful, or like how, whatever the existing data, like, is going to helpful for, or I'm going to improve through my project with this data, or something like that. You have to be very, very, like, impactful for your research question, and it has to be very innovative, and you have to be answerable for those. So as I said, like, I had to, before writing the proposal, the grant proposal, I had to look some data, as I think, like, for any proposal, you have to find out the data, like what is the existing proposal for, like, close to your project, and why I'm doing this. So what makes me think about it, this data is basically available for anyone. This data I collected from Michigan Care Improvement Registry data. It's called Maker. So it is like, it provides like how many people are the vaccinated, what type of vaccine they got for every year. So when I was writing my proposal, that was in 2021, around this time. So I collected like 5 years data. And if you can see about this data, this is the vaccines data from 1 month children, 3 months children, to 1 month to 24 months of the children's data. So you can see back in 2016, like, the vaccines rates were basically like did not decline much. But if you compare from 2016 to 2020, you see that, like this, it's like 2020, basically the vaccination rates are much lower in compared to 2016. So, but however, if you compare that, one of the vaccines that did not decline much is actually the vaccines they got after 1 month later. Why this did not decline? Because the only vaccine, hepatitis B, which is actually administered to the children after the delivery, within 24 hours of the delivery. So what happened, like, the patient who goes for the delivery, the children got that vaccines right there. So only that vaccines did not decline. Other than that, like, you can see from 3 months to 5 months to 24 months, all the vaccination rates back in 2020 was declined. So these data basically suggest me that my work would be, I mean, I need to do on this work, and the people need to increase in this group of population needs to increase their vaccination rate. And how can I improve their vaccination rate, and what are their barriers and challenges? So those are my questions. So anyway, as Lubaba mentioned, although we may write our grant proposal any format, like, they have their own format. Every grant proposal has their own format. So no matter what, like, we have to follow that format. And it's very strictly, they follow that format. I mean, we cannot modify that format at all. So, that was my questions. Like, I questions myself, but these was the questions I received from the the proposal, like the reviewer. So the questions they asked me: who is the target audience for your proposed project? What demographic factors will you use to identify or recruit your target population? What is the health disparity or inequity you propose to address? Please be as specific as possible, and please describe your proposed community service project, including the following, like project goals, meet these goals, intended outcome, and then if you are proposing to a program, that please briefly describe how you might expand or build upon it. That means the sustainability, as I mentioned, and what are the challenges to your innovation. So these are the questions they asked for me, basically, that I have to answer. I will, describe a little bit about those answers, that how did I answer their questions. So first questions was like, what are the patient demographics, and, what is your targeted group of population? Why did I target those group of population? Because as I mentioned you, that data shows that their vaccination rate is very low, and they have multiple barriers, and also due to pandemic, those are the underserved population. So some of them lost their job, some of them basically lost their health insurance. Some of them are like not able to come to the hospital or like, in the health center, as because they do not have a vehicle to come. So there are multiple barriers. It is not only they don't want to take the vaccines. Some of them want to get the vaccines because of the barriers and challenges they are not able to. So my project was like, how can I overcome those barriers? How can I reach out to them, with the vaccines, and that will resolve the barriers. So that's why I basically targeted those group of population. It's mostly on the underserved population in Detroit, and their demographic factors was like, I include their employment, education, income, marriage rates, birth rates, comorbidities, and other things to identify the targeted population. And also, I want to say something like, it's underserved population on the Detroit, but I also, as being, I'm from Bangladesh, so there is a city in Detroit where the, like most of the immigrant people from Bangladesh, they came, and by the time they reached to US, they are most of the time they are their 40s or mid 40s, so they have multiple barriers, such as language barriers, such as like, they are very new in this country, so they have multiple cultural shocks, and at the same time, they struggle themselves to feed themselves. At the same time, they're struggling to adapt the culture and all that. So during like 2019, when they arrived, it seems like the immigrant population in Bangladesh, especially in the Metro Detroit area, whoever come from Bangladesh, their vaccination rates are very low. And those are the people, their hospitalization and mortality rates are very higher due to corona, COVID vaccines than the others, because all these social determinants of health. So, I try to resolve those barriers as well, because as I know the language, and it was easy for me to communicate to them, and then understand their barriers, and then resolve those. As Lubaba mentioned, that very important to collaborate with the other people. When my project was accepted, that's my next step was, how can I collaborate to other people? So I collaborated with community leaders, even like I made multiple cultural multiple vaccination camp in the local mosques, local temple, and then local restaurant, local library. So by that way, like I can talk to the people, and then I can convince. I don't want to use that word convince. I want to convey the message that why vaccines is very important, how it gonna prevent those people from getting the vaccines, from other disease and whatnot. So, and also it was, as I mentioned, there are some people who cannot drive, and who does not have a vehicle. So if we by organizing those vaccination camp in the local area, it helped them. Basically, they came there and they got the vaccines, and then I provide them some education. So all those are their barriers, and I try to resolve those barriers by collaborating with other people, such as community leaders, like public health workers, public health educator, as well as like community members, such as library, head of the library, or like the schools, or like some of the people from the mosque, or like temple, something like that. So collaboration is very important in terms of, to be successful to your program, or like, you cannot do it alone. So, you need to collaborate with multiple and multidisciplinary group of people. So that's the message I want to give you the same way. So my next question was for the research questions. I'm coming back that, history was shown one of the largest challenge for the vaccines distribution, convincing the people like vaccine safety and efficacy. and also the people distrust, public distrust. This is like, there is a history among like African American people of about the Tuskegee study that they are behind from the clinical trial, they are behind from their other science trust and whatnot. So those are the very challenging things, and I think it's very important to know their history, and it is very important to acknowledge that in front of them that you know their history, and by knowing that, you try to overcome that. Now, I mean, you can challenge them. So, I mean, you can convey the message that this is not the same story here, and then we are here to help you, and if you have any concern about these vaccines, we are here to we can answer your questions non-judgmentally. But you have to be very actively listener to them, and you have to make sure that you are not judging their clinical decision or their their attitude or their it has to be very non-judgmental, because this is a new disease, and everybody has a concern, everybody has a questions, but we are not there to judge their knowledge. Instead, we are there to resolve their I would say like to overcome the conflict, and as well as convey the evidence-based information to them. So that was my whole idea, and my goal was, like, as we know, the sustainable developmental goal, basically from this is proposed by WHO, that like to a healthy lives and promotes our well-being to prevent vaccine preventable diseases for all the peoples in the world, all the child, which will basically gradually decline the child mortality rate. So that's my goal, that this counseling and this intervention probably ultimately will increase the awareness and positive behavior on the immunization, and as well as it will prevent the child mortality rate. So some of the things, like I would say that as I divided this program, this goal into multiple categories, such as for the children, it will decrease the child mortality rate. However, like there are some vaccines which can prevent even cancer, such as HPV, which is very, I would say, like the people I had worked with, as HPV is like, administration, basically we administer the vaccines in age of 9 to 26, I would say. So those group of people, like, they do not have much education regarding the HPV vaccines. So I was about to I was invited by so many even schools from Detroit, that even some of the I would say like a community health organization, that how vaccine can prevent a cancer, like in a teenager groups and whatnot. So, like, those type of education is very important in terms of, even like, we may think this is like well known. No, this is not well known for all the people, and you have to always think that you're working basically with the underserved population. So that's why I made it like a teenager people, childhood, and even like I talked about some geriatric vaccines, which is like I want to emphasize here, because we are here, we all are here for geriatric fellowship. So anyway, like I emphasize on geriatric vaccines such as pneumonia, flu, and shingles. So there are multiple barriers for those vaccines, such as like pneumonia vaccines. There are multiple barriers for the people who can have, like, some people can have these vaccines after 65. Some people has to take because of their comorbidities before 65. Some of their insurance does not work, if they want to get the vaccines before 65, and why those insurance are not covering their immunization. Even same with the shingles. Like, I want to prevent shingles because it's very painful, especially the people who are living in nursing home, or whoever, like, they cannot come very often to the doctor's office because they have to depend on the vehicles, or like one kind of like their insurance probably provides some transport for them. So, like it's better to discuss those things. And there are nowadays, most of the visits, like the visit does not require any blood work or any lab work. People prefer telemedicine. So once they come to the doctor's office for like any kind of like the in-person visit, is better to discuss vaccines at that time. So by that way you can catch up the vaccines. But I found out that there are multiple barriers for the the shingles vaccine as well, because people who are below 65, if they want to get shingles vaccines, they cannot get from their primary care physician. They have to get their vaccines from basically from the pharmacy. So like, I have to collaborate with the pharmacist also in order to go, in order to administer the vaccines for those group of people. So my overall goal was basically decrease mortality from the, vaccine preventable disease, and as much as possible, and build the herd immunity overall. So my next slide, what I kind of probably I kind of describe what did I do to meet my goal. What are the possible basically activities? So, like I of course educate the parents, family, and I educate them for the importance of the vaccination and immunization schedule. Okay, that's another goal. Like so many people, let's say hepatitis A, it's basically 2 doses, hepatitis B, that is 3 doses. Measles, mumps, measles, rubella, there are 2. So there are multiple vaccines, multiple doses. So the people does not have much idea about the schedule. So basically they thought one vaccines is only, some of them like thought like it is 1 dose and done. So I have to contact those people, like, your second dose is coming. And, if you don't, basically if you complete your dose or your child dose, basically they're partially vaccinated versus completely vaccinated, because partially vaccinated means it will not provide you the full immunity. It will only give you the partial immunity versus full immunity. So those are the education I provided. And then, if patients like missed, or the parents missed, or any vaccine dose, I provide them like what's the importance of fill up the missed vaccine dose. And I try to understand determine their cultural, religious, and misinformation in restricting their behavior, because some of the parents, like especially when it was I think the vaccines, when the COVID vaccines was approved for the children 5 and above, some of the parents, I mean, I am also a parent, I think I have some, at that time I had a little bit hesitation too, that will it really work for my children, and how safe is it? So I understand their perspective as well. And there are so many misinformation, and the unfortunately the people now depend on more, I would say, like social media information than the real site. When I talk to them, I try to convince them, please, if you need to know any information, please go to like trusted website or evidence-based information such as CDC, WHO, those website, or like Michigan Department of Health. Instead, but don't trust any social media, whatever your friend or your your friend's brother or whoever, like, tag you for some misinformation, which is very irrelevant. And so I was like, sometimes I was not prepared for some of the questions, but I still they asked very weird questions, such as like somebody asked me, like, I heard these vaccines was made out of toxin material from the dead fetus, and it is going to kill my baby if I give the vaccines to my child. So, I have to convince that how vaccine works. It did not, although these vaccines was made in 9 months, but it did not compromise any steps of the clinical trial. And, it says it's as efficacy and safety wise, it is as effective as other vaccines. So those are the information, and those are the health literacy issues I provide to them. And I feel like this is very important for the community, and to, create a positive behavior. And also, like I made some example that see, like, why we are now, it's a polio free world, but back in like 40 years from today, the polio was, and measles was like a very endemic. And then like there are a lot of children who are died, and why you are polio free? Because we are able to, because of the invention of the vaccines, we are able to administer those vaccines. And I mean, only like very couple of the countries, probably Pakistan, Afghanistan, or like there are very small amount of cases of polio, but other than we are basically polio free because of the vaccine. So we have to trust the science and this technology and whatnot. So I use those kind of information. And also like as I mentioned that whatever that other barriers such as cultural, such as transportation, such as language, and those also are the barriers. So I try to overcome those barriers as well. So that's are the possible activities I did to meet my goal. And these are the some pictures taken, and it was, I think, posted in the social media that how a public health student from MSU is providing the health literacy and educating the underserved population regarding vaccine hesitancy. And that's how I used to talk to the people. I arranged some this was a picture taken, I think it was a vaccination camp, and I as I told, I collaborate with the pharmacy student in Wayne State University and also Michigan State University. And I also collaborate with so many resident physicians who helped me a lot during their off hours to volunteer to do those, administer the vaccines, because I'm not basically, I'm not authorized to provide vaccines. I can provide the education and arrange everything else, but so that's why I had to collaborate with the pharmacy student, resident physician, and other community members in order to build this trust and in order to do this type of campaign and health literacy thing. So my intended outcome was like, to identify basically build the trust in vaccines to the population, of course, the vaccination rate, and reduce mortality. And I want to improve their motivation actually and behavior for the vaccination. So I want to see their attitude about the overall attitude about the overall vaccines, and of course the education and confidence. My intended outcome was not to create a positive behavior to the physicians, but what I found when I was working in a clinic in Detroit, I found that some of the resident physicians, when they see the patients, they basically come to me and ask like, what are which of the patients is due for what kind of vaccines, and they want to make sure their patients are all up to date with the vaccine. So I was very satisfied to their behavior, because they understand after almost the end of my project, at least the resident physicians and the other people also were able to understand that it is very important to up to date all vaccines, and it's probably it's very beneficial for their overall overall I would say like the outcome of the patients, and also it will decrease the overall healthcare cost, because a patient who has a probably flu plus pneumonia or something, if we provide the vaccines, they don't need to go to the hospitals because it will prevent the pneumonia or shingles. So it will also decrease the overall healthcare burden and cost. So I mean, it was one thing like I want to make sure that it was a positive. It's not only positive behavior for the people, but it creates the positive behavior for the healthcare workers such as resident physician and nurse. So this is my basically the interventions for that was my total model that I was included to my proposal, that what I'm going to do, what are the intervention for the parents, for the providers, and for the clinics, and as I all the activities I mentioned, and what are my outputs. Of course, the outputs are like quality of the vaccination service and improve motivation and behavior. And these are my outcomes, like it's the total I want to prevent the whole total outcome was like probably I want to decrease the child mortality rate and the vaccine preventable disease, and ultimately it will create a positive behavior for everyone. So that was the total things, and if you guys have any questions, you can ask me. And thank you so much, and I wish you all the best, everyone, for day after tomorrow.
Thank you so much, Dr. Somi, for sharing your experience. Anyone has question?
Thank you so much, Sylvie. It's also great. Thank you, Dr. Lubaba, as well. Both of you presented a good approach and your experience. Thank you for sharing. Excellent. Any questions for Sylvie or Lubaba? So the idea is in the future, when you get into residency, hopefully soon, you might think about research projects. It may be required. While doing that, maybe you can think about also getting a grant. Some of the institutions, academic institutions, they have funds, so maybe you can think about that. So it's just the process of how you can get the forms, how can you put your idea into descriptive and fill all these forms. And you will find someone to help you. Usually it's a process, so most likely people before you have done it, and there are some staff member who knows exactly the details, so you will get some help as far as completing this task and forms and budget and so forth. Good, excellent, thank you so much. And we have Dr. Wael Al-Safi with us, and he will talk about other opportunities. If you are available, Dr. Safi, please.
Assalamu alaikum. Good afternoon, Dr. Nadir. Yep, I'm available. Yeah, I will talk briefly about Mayo Clinic research opportunities. So, from my experience when I was started until now, and the process, the application process, and the role of the researcher, what's going to be doing there. So the program itself is called Clinical Outcome Research Program Support. So you basically send your CV with a cover letter to the research coordinator. There's two ways of getting a position. Either send your CV and your application to the research coordinator, and I can provide you with the email that you can contact. Other thing, if you know someone from working in there, if you have someone working in there, he can take your application and give it to the research coordinator, or he can give it to the person or the mentors that you're going to be working with. After they get your application, if they have a position, if they want to offer you a position, so they're going to contact you, they're going to interview you, and then the application process takes approximately 4 to 6 weeks from if you need a visa or not. There's a lot of things on it. And they have start dates. Every month, they have like 2 or 3 start dates. On that start dates, when you start, they give you orientation, and then you take courses that you're going to use in the research, like EBIC courses, what you're going to be doing. There is a certificate you need to be doing in the courses, online courses during the first week, and then you start working right away. So the rule will be mainly, your main rule will be data collection. So in general, here at Mayo Clinic, they use something called RedCap. It's like Excel sheet, but it's more modified than Excel sheet. So you search in the EBIC for the patient records, and you collect the data, pull out the data, and just enter it into the RedCap. This is a major rule you will be doing. But also you can create your own project. You can be working with colleagues, with other fellows on other projects as well. Duration wise, it usually a year research fellowship. They like to call it a research internship. So they will be referring you as a research intern, and you will be working with mentors. So every research intern has a mentor, depends on the mentor himself. Some mentors have more than one research intern, but most of them, they have just one research intern. And you will have other opportunities as well. You will have access to a lot of resources, a lot of learning tools in in the Mayo system. So you will be provided by email, with Mayo email. You will have access to their website, and when you get into the website, you will be part of the system of the hospital. So they will share with you if they have grand rounds, if they have lectures, if they have any other opportunities. And then it depends on which department you are working on, which mentor you are working with. If they can offer rotations, observerships, or you can participate in rounds like observing clinic. So, and of course they will provide you with a letter of recommendation at the end of your period there. This is briefly my research so far. When I started back in June until now. So the work itself depends on how much you can do during that time. If you want to do more than one research, you can participate in more than one research. So it depends on you, basically. The more you can do, the better for you. Like they give you a task. If you complete the task, they give you another task. So it's mainly on you. And the only setback, the only bad thing about it is unpaid research opportunities. So you will have to provide for yourself. But it's also that there's a good thing on that. They don't get in your head. They don't tell you do that, come at the specific time and just finish it on the specific time. They know this is a volunteer job and you don't have to do it in a very specific time. It depends on you, like how hard you work. The more you do, the more you get publications, the more you get done. That's basically a brief scenario about it. If you guys have any question, you can just ask.
Thank you, Dr. Wael. I have one question. You said we send our CV to research coordinator. What type of experience should we have before we apply? Do we have to have published research before?
No, not necessarily. You just have to build up your resume. Like it doesn't matter what do you have on it. It's just like whatever you have in your CV, just send it. And of course, if you have a research experience, that will be a benefit for you, but it's not necessary. It does not affect anything.
Okay, thank you. Next question about the schedule. You said it's not.
It is flexible.
It's up to you, right? So what is the usual work schedule for the research? Can I do another thing, another work besides the fellowship? Mm-hmm.
Yeah, it's flexible. It's flexible. So you basically do the if they give you a project that you are working on, you have to come to the hospital. They have buildings for research. You come and it's open 24 hours, 7 days a week. You can come whenever you want, do it, and it's flexible. You don't have to come at a specific time and leave at a specific time. But if you want to join other activities like rounds or like be in a clinic or observe, then you can come during the regular hours.
Okay, thank you.
Yep.
Dr. Muhammad Ibrahim has a question. Go ahead, Dr. Muhammad.
Yeah, first of all, thank you, Wael, for this great information.
You're very welcome.
I want to ask some question though, like need some briefing about the life in Jacksonville, the cost of the housing, if you can do jobs to just survive there. Yeah, those things can like this. Thank you.
Yeah, yes, of course. It's the good thing is there's a lot of research intern from all over here in this program, and around the hospital there are houses that provide housing for if you are single, if you don't have family. They provide a room, for example, and you pay a rent, like a monthly rent. Or if you have family, you can just rent an apartment. The cost of living, I would say, it's not cheap. It's pretty kind of expensive. It's not like I cannot compare it to a different state, but it's not like an average 2-bedroom apartment is going to be $1,600, $1,800. So other work you can do, you can work in. There is a lot of opportunities, I think, for work. medical assistant, you can work as a, or you can do a lot of work. If it depends on how, like what experience do you have? It depends on what are you looking for, how many hours you can work, how it totally depends on the person himself, I think. Does that make sense?
Yeah, thank you so much.
Yep.
Any other questions?
I have a question. Thank you, Dr. White, for this information. I know some research places, like say in Johns Hopkins and other places, they do not. You will not like publish any article or anything. You do data collection, and they give you only the letter and help you to the match. It looks like it's different. Are you like publishing under the name of Mayo Clinic, or like with the attending there, or not?
Yeah, you totally publish in like if you are working with your mentor and he has a project and you are working with him, and the publication is very fair. It depends on how much work you did on the project. Like if you, for instance, if you do the most of the work, you can go into second author, or even if you can do your own project and you get publication. So publication is a big thing. They understand that you want to do publication, you want to make as much publication as possible. So that's why they give you as much project as possible to do it in a very short time.
Thank you very much.
Thank you so much, Dr. Weil. Hopefully you don't need it, every one of you. Hopefully you get the good news and you start your residency right away. Just in case it's like plan B, to think about other options, especially for single people. It might be an easier option. Thank you, Dr. Weil. Thank you, all the presenters. For the next part, maybe if we can get an update. We have good news that we presented 2 posters during the meeting. So I think Dr. Ala is here, or if anyone wants to update us about the poster. Dr. Hadil excused herself. She couldn't participate today, but she was one of the presenters. And Lena, I think, go ahead if you have any information that you want to share, or others. Thank you so much, Dr. Weil, again.
You are very welcome. Please, if anyone has any other inquiries or any questions, just reach out to me. Thank you.
Thank you. Have a wonderful day.
Yes.
Sorry, I'm not sure whether Ala is here or not. I am Sarah. I presented with Ala. So yes. We presented a poster about the pain management among nursing home residents, a systematic review. It went well. We've been asked one question and Ala did well on answering that question. And they were like saying it's a good topic, an interesting one. That's it. Yeah.
Excellent. That's good. Did you like the experience itself?
Yeah, definitely. It's the first time I've submitted a poster before, but the first time actually to present lively and in front of judges. It was definitely a great experience. Yeah, and we were even more prepared. Sometimes when you do only poster, you do like, you know, it's fine, specifically with the virtual type, but we were more prepared. We knew the topic in and out, and like, yeah. So it was a great experience. Definitely, we learned a lot. Thank you. Yeah.
Excellent. Thanks for sharing. I think Afrah also, Dr. Hadid mentioned you were present. Do you want to share?
Yeah, I represent in both projects. Yeah.
How did that go?
It was good. They asked
a few questions.
Yeah, a few questions. About the research in the future, why we don't reach out to the residents themselves directly, not the activity staff, like that. Yeah.
Excellent. Yeah, they have good questions. So, and I think you and your team mentioned that we have some plans for the future, which is good. That's good. Excellent. So it's nice when we get this poster accepted and to present, the interaction itself might be a new experience for you guys. And hopefully when you start residency, you will have at that time opportunity to present in person. You will be required to either present oral or poster presentation in local or national or international conferences. So this will give you an experience that it might be easy for you when you are in that position. Good. Excellent. Thank you, everyone. Go ahead, Dr. Afar, for next. I think we are
So
done
the
with-
last topic is how to do focus group research. I'll share my screen.
So I just want to make sure for everyone else, if you have to do anything else, I know it's 2 hours now. If you can stay, that would be great. Otherwise, this will be recorded. Thank you.
So the last topic is how to do focus group research. We'll start by definitions. A focus group is a form of qualitative research in which a group of people are asked about their perceptions, opinions, beliefs, and attitudes towards a product, service, concept, advertisement, idea, or packaging. In other words, the focus group approach is a qualitative method to collect the data on the selected topic with a structured and focused discussion in a small group of people. What are the purposes of focus groups? Focus group discussions are often used to explore patients' experiences of their condition and interactions with health professionals, used to evaluate programs and treatment, used to brainstorm product ideas, concept, and communication idea, and also used to develop questions or concept for questionnaires. The goal of the focus group is to provide useful insights on the topic. Planning and research design for focus groups. The pre-planning and design of the discussion as well as its environment play an important role in conducting focus group sessions. The common and simplest method for selecting participants for focus groups is called purposive or convenience sampling. So it is purposive sampling, not randomized. To organize the focus groups more effectively, the approximate length of the focus groups should be planned in advance. The ideal length of the focus group sessions fluctuates according to the advice of different researchers between half an hour and 3 hours per focus group. Focus groups generally consist of 6 to 12 participants. The people participating in the focus group discussion share certain characteristics like professional background or share similar experiences like having diabetes. Because participants with different backgrounds and experiences can restrict the openness of discussion within the group. The moderator facilitates the interaction within the focus group with a set of previously planned open-ended questions. It is very important for the moderator to plan opening remarks, questioning sequence, physical setting, and other materials effectively to make the focus group discussion successful. People who participate interact with each other. This means that instead of the researcher asking each person to respond to a question in turn, people are encouraged to talk to one another, asking questions, exchanging anecdotes, and commenting on each other's experiences and points of view. The moderator uses their interaction to collect the information he needs on a particular topic. The moderator should be a good listener with adaptable attitude for the entire discussion to make it effective and successful. The level of moderators' participation or involvement varies at different stages of focus groups, depending on the intensity of discussion. The moderator's involvement depends also on the course of the discussion, whether it relates to or deviates from the topic of research. Data collection and data analysis of focus groups. The mostly used methods for data collection are note-taking or recording. While the best way to collect the focus group data is to record the complete session, it can be audio or video recording. The qualitative summary, thematic analysis, and content analysis can be used. Systematic content analysis can be done by using the lexical analysis method. Advantage and limitations of focus groups. The advantage, less expensive than some other research, and the fast way of gathering a lot of insights. Limitations, no generalization of findings to the whole population. As we said, it is purposive sampling. Less control over the data. Effect of the most dominant character, experience, commitment, respondents. So we recap what we talk about the focus group. First of all, we determine the topic and goals of the focus group. Then identify potential participants. Then prepare a guide, the moderator guide or discussion guide that outlines the focus group questions. Then choose a location for the focus group. Recruit 6 to 12 participants who receive an incentive. Then conduct a 90 to 120-minute session led by a trained moderator. Then analyze the session. Then analyze the session and present a, cannot see here, through written and or oral report. So this is about the focus group research. Thank you, and you can ask any questions.
Thank you so much, Dr. for this concise and to the point presentation. So it's one type of or one method of doing research. Usually it's getting information from people. The same way they asked previously in the poster presentation. They presented about the activity in nursing homes. So we ask questionnaire kind of approach to the team that provide the activity. So the other method, instead of doing a questionnaire or sampling, you can sit down with the same group, like activity personnel, plus the resident or the patients. You can add some family members. So all of them are talking about the same topic, basically COVID and limitation of activity during the period, let's say, when they were confined to their rooms or limited activities. So you can discuss about what they are feeling, how they experience that, and the patients may share some of their input there. The activity personnel or the team might tell you about what hustle they went through, how they overcome the problems there, and you can get all this recorded and then divide it into themes or sections where each one can be supported by some of the comments from either the patient or the family or the activity team, something like that. And then you can publish it in a way that like transcript, send it and be published. So excellent. Thank you so much, Dr. Afrah, for sharing all this information.
Thank you.
Any other questions, any other comments? If not, maybe we can go to the last, I think, part of the agenda. So for the next meeting, suggestions, I know it's going to be results presidency. Hopefully we hear good news about every of you. I put some, it's going to be the Brown team. I put some suggestions there. So I'm going to just share that with you guys. So, So maybe someone can present something about osteoporosis. If Avinash with us, if you want to do that, or
yes, doc, I will do.
Okay, thank you. And you can discuss the other team with the team members about if we want to go. I think it will be out of the scope at that time. Not, we can talk about other topics. And if someone can also, Sarah, if you, Sarah said if she is present, maybe she can also talk about research data, how we can use that as a networking approach where you can improve your resume and your name to be in the publication area. So maybe someone can present also evidence-based medicine if we have some time. So if the team is available to do that, that would be great. If no one is able to, maybe Avinash let me know and I can help you with supporting for next meeting. I know it's going to be easy for some of you. Any question or any other suggestions?
I have suggestion, Dr. Nader.
Yes, please.
I mean, instead of talking about SOAP, because it would be
after SOAP, yeah.
If someone can present how to apply for residency outside the match, I mean, how to reach out to programs that are not participating in ERAS, or I'm not sure how can we reach to the residency programs.
So I think that's a good idea. And in the past, I think, if I'm not mistaken, Dr. He mentioned a way, maybe Lubaba or Sumi can help me last year or the year before. They were discussing about how you can send an email to the programs after the match, already the match there. And I did that with when I finished my first year. What I did is I collected all the information about the programs in internal medicine, contact emails, and so I sent a mass one same email to all of the programs. The content is very concise, just 4 or 5 sentences. Highlight your resume basically. So you can mention that you are finishing a fellowship in geriatric research, telemedicine at Michigan State University, and maybe some of your other clinical experience or other activities that you have. And then you are interested in their program. So this might be an option, but we can discuss about other options as well. Excellent suggestion. I added to the agenda for next.
Thank you.
You're welcome. I'll try to invite Mulham and as well. So
I
they
think
might, yeah. Go ahead, Sumi.
Sorry to interrupt. I think Aja also can provide us some idea. I think she matched in a like a fellowship program, like
Yes.
so it would be better like the people. I mean, I hope that everybody will match, but if someone doesn't match, what's the next step? Like either apply for like non-traditional residency, like outside the match, or like the fellowship program. So Aja probably can help us for the fellowship program, and yeah, the residency program, we can search and see how that goes. I think this is a very stressful week for all of us. It's hard to concentrate on anything. Yeah.
So
Yes, yes, sure. Thank you, Sami. Yeah, yes, sure. I will be happy like to present or talk a little bit about how to apply to fellowship.
Excellent. Thank you so much, Sonia and Azza. Excellent. Thank you so much.
You're welcome.
I added that to the agenda. And I don't see Krupa. And congratulations to Azza and congratulations to Krupa. She also matched in fellowship. No, I think it's presidency, pre-match, pre-ERAS or some offer. So she already matched for her program in psych, which is good for her. Congratulations. All right. Any other agenda suggestions or any ideas, any questions about the projects. I know we have two posters will be presented in the coming Cardiology Association meeting. So we are excited to also present that. I wish you all the best. Next week, hopefully we will hear good news. And thank you so much, Dr. Afrah, for moderating this Zoom meeting. Thank you everyone for attending. And those who couldn't, thank you if you look at the recording later. I wish you all the best and keep me posted. See you next week. Have a wonderful day or night. So,
Thank you so much.
Good luck, everyone.
Thank you.
Good luck with the rest of your weekend. Bye-bye.
Bye-bye.
Thank you.
Bye-bye, everyone.
thank you.